T&M classification. Thank you very much to the teams for that. We're going to now move on to thoracic trauma, and I want to welcome our expert, Tamas Molnar from Pecs in Hungary, and he'll give us an introduction. Just reminding any latecomers, anyone who's in the audience who's in, please use the app. Go to the app, go to the postgraduate section, click on that, and you'll find that there's a category for voting, and you can vote along with the teams. Okay, Tamas, please.
Well, thank you. Good morning. This is a blood, sweat, and tears session. So the chest trauma. Could we proceed? Or? Yeah. All right. Sorry. Major chest trauma is responsible for 1/3 or 1/5 of a preventable death, but it's quite rarely monotrauma. The hemorrhage and the lung parenchyma problems are in the focus of our interest. The problem is that in the average thoracic surgical department, the caseload is low, usually less than 5 procedures per year. I'm talking about the major cases, and there are no two similar cases. When we are discussing these differences between the trauma and the thoracic surgery, the general thoracic surgery, the principles are different. They are running against time, and we are in the fever of the minimal invasivity and oncology-driven mentality. The mindset of the thoracic surgery is for the individual lung cancer case. These are complex decisions, full pre-op checkups as we saw it, more or less pre-identified pathology, and we are working in a properly structured and controlled environment. And our evidences are well-based, usually level 1 or 2. On the opposite side, the decisions are based on common sense and trauma, and chest trauma included. The decision-making trees are short. They have an unknown patient. The condition is severe. Under pressure of time, we are, as thoracic surgeons in this situation, out of our comfort zones, and the level of evidence is low, as actually randomization in acute trauma is a dream. So when you will consider the cases, please keep in mind that Kipling's poem, a keepsakes, honest serving man. They told me all I knew. Their names are what and why and when and how, where and who. So chest trauma, just remember, is terrible simple. 95% simple and 5% terrible. So let's see the cases.
Thank you very much. Thank you, Tamas. And we'll move on now to the questions. Do you want to take a seat on that? And we'll. So the topic is thoracic trauma, and the first section is going to be emergency and resuscitative, and we're going to ask Team Europe to present their scenario and pose their questions. Rory Beattie.
Thank you. Okay, so this is a 73-year-old male. He's a background history of peripheral vascular disease and chronic obstructive airway disease. He had a witness loss of consciousness while driving and was involved in a high-speed collision at 120 kilometers per hour. He was cut out of the car, and his Glasgow coma scale was 8 out of 15 at the scene. He arrives in the emergency room by ambulance. On arrival, he's an ET tube in situ. He's saturating well on 100%, and he's reduced air entry down his right-hand side. He's a right-sided chest drain inserted with 900 mils of blood out. He's hypotensive and tachycardic with a metabolic acidosis. He's a pelvic binder in situ, and his long limbs are intact. His pupils are equal and reactive. Fast scan in the emergency room shows no tamponade, a right residual pleural effusion, and a small amount of free fluid in the abdomen, although that's somewhat uncertain. So, question to Team Asia, what is the next step in the management plan? 1, initially 2 litres of warm crystalloid and diagnostic peritoneal lavage. Number 2, O-negative blood, tranexamic acid, then whole body CT. 3, permissive hypotension, urgent transfer to theatre for damage control thoracolapparotomy, or an urgent transfer to hybrid operating theatre for minimally invasive surgery and angiographic control with rib fixation on the way out.
Okay.
So you have 30 seconds to formulate your answer. And audience, this is your time to vote. Okay, time is up. Could we now have your answer, please?
We would like to go for.
Hang on, just get the microphone on, please, for Team Asia.
Can't hear it.
Hello?
Yes, okay. That's it. We can hear now.
I would like to go with the option of 3. While the initial traditional teaching was that we should first manage shock by giving 2 liters of warm crystalloid, and diagnostic peritoneal lavage would not be a good option right now because he has a right pleural effusion with some fluid in the abdomen. O-negative blood and tranexamic acid are the correct choices to think of, but whole body CT in a patient in shock is not to be considered. As far as the third option goes, urgent transfer to hybrid operating room with minimally invasive and interventional angiographic control with plate fixation on the way out seems a little ambitious and may not be a very, especially for the plate fixation of rib fractures on the way out, seems like not a part of damage control, and the patient seems to be in shock. So I would limit my choice to permissive hypotension and urgent transfer to theater for damage limitation thoracoleprotomy.
So Asia's answer is number 3. Okay?
Is correct. Number 3.
Asia, you're
Number 3.
number 3, yes. Okay, so we'll now move on. Rory, the second part of the scenario, please.
So the same scenario, this patient went for a whole body CT. It showed a small subarachnoid hemorrhage, a thoracic spine injury, extensive right-sided rib fractures, and a small remaining hemothorax. It had a grade 2 liver laceration. The liver injury was treated conservatively. The thoracic spine was fixed on day 2 after admission, and the patient was cared for in intensive care. It had a repeat CT head on day 2 that showed a left-sided infarct, which would explain the initial loss of consciousness while driving. So day 3 after admission, the thoracic surgeons are asked to re-review the patient to consider the role for chest wall fixation. On review, he's still intubated. On wean sedation, he does not obey commands. He's moving his left upper and lower limbs, but no movement on the right-hand side. He's oxygenating well, and on a trial of spontaneous breathing, he has paradoxical movement on his right chest. The neck collar remains in situ, and there's a concern about an occipital condyle fracture, for which he's awaiting an MRI. And that's his 3D reconstructions of his chest wall and his current chest x-ray. So question to Team Americas, what is the role for the thoracic surgeon? 1, appropriate muscle sparing incisions with fixation of all components of flail segment, thoracoscopic inspection of diaphragm, and appropriate drains and pain catheter. 2, use of single lumen ET tube that's currently in situ with a limited smaller incision over the worst affected area with rib fixation. 3, consider rib fixation only if MRI excludes neck injury. Or 4, no surgical intervention at present.
Thank you very much. So you now have 30 seconds to formulate your answer and for the audience to give us their vote as well. Do you need to see any images? Okay, 15 seconds left. Quite a few options there. Aggressive or conservative. Okay, your time is now up. Could we have your answer, please, Americas?
After discussion here with the team, we believe that the best answer in this scenario is number 2 with some, considerations. We believe that in this patient with multiple trauma, multiple comorbidities, a limited intervention would be in his best interest. It seems like there is an indication to fix his flail segment. However, we would like to consider that only after all the other acute injuries have been addressed. It's still too early, and I think the rest of the trauma should be addressed first before addressing the rib fractures.
So on the basis of that, you've gone for number 2, is that correct? So answer 2 from the Americas. So we'll see what our expert thinks of that in a minute. Okay, so now, thanks very much, Rory. You can take a seat. And over to our panel. We want you to score the scenario as presented by Team Europe, starting with 9 from Frank. We've got a 10, a 9, an 8 from Arvind, 10 from Walter, a 10 from David, a 7 from Akif, and we've got a number 8 from Dr. Kida, an 8 and a 7 from Dr. Kasivi. So that's the scenario. We're now going to move on to your score for the quality of the discussion and answer from Team Asia. So from Frank, we have a 5, a 4 going down here. Julia, thinking, make up your mind, and it's a 7 and an 8, a 7, a 6 from Alessandro, 2 from David. Well, radical voting here. A 9, a 7, a 6, and a 7. So we've got all the answers in there, the scores in. So now we want you to score the Americas for their discussion and their answer. For the second question, Frank. Thinking again, taking our time. Oh, he hasn't played Strictly Come Dancing, has he? Number 7 and a 6, a 7 and a 7. Walter's got a 6, a 5. David's at 3, a 6, a 6, a 7, and an 8. So our scores are all in for our trauma. So we now want to move on to the second part of our trauma scenarios. This is the early management, including the role and timing of VATS, chest wall fixation, and intensive care. So I'd like the Team Americas to come up and present their scenario, please.
So this case is a 48-year-old male patient that is brought to the emergency room by paramedics after a motorbike accident with mild head injury, transitory loss of consciousness, hemodynamically stable, but in respiratory distress. In the emergency department, he underwent chest tube insertion and 280 milliliters of fresh blood come out with a severe air leak. The chest x-ray was as follows. There are multiple rib fractures and a left shoulder crush at the costoclavicular area, injury with fracture dislocation of the left sternoclavicular joint with suspected scapular fracture. A CT scan was performed showing pulmonary contusions, subcutaneous emphysema, pneumothorax, and rib displacement as shown in the pictures. A CT scan with 3D reconstruction evidence of flailed chest from the 2nd to the 5th rib. Question to Team Europe. In the present case, all of the following indications to surgical stabilization of the chest wall by rib fixation are correct except okay. Number 1, to manage acute respiratory failure associated with the flailed chest and decreased pain. To shorten mechanical ventilation time as well as days in the ICU. To decrease the incidence of pneumonia, the likelihood of undergoing tracheostomy. To speed up recovery to work, which makes the procedure cost effective. Or number 5, to decrease the mortality rate.
Okay. Voting starts now. You've got 30 seconds to give your answer. Audience, you've also got your 30 seconds. With the theme music building in the background. And 15 seconds to go now. Halfway through. So that's the time up. Now, let's hear from Team Europe, please. What is your answer to this question?
So we're going for option number 5. It does not decrease the mortality. There are 3 randomized controlled trials now, the biggest one probably being the Moresco trial from Australia that shows chest wall fixation in flail chests in intensive care would reduce the ventilation time, reduce the incidence of pneumonia, and can speed up discharge, which would also make it cost effective and increase return to work.
Okay, so we move now on to the second part of the scenario. Do you want to present?
So now the question to Team Asia. So all of the following indications for surgical restoration of traumatic failing chest wall injuries are established or reasonable except number 1, more than 35% severe contusion of the lung surface. Number 2, on the way out, thoracoscopy and thoracotomy. Number 3, failing sternum, a gap between the fracture components. Number 4, major flail chest, more than 3 ribs.
Okay, time to answer. You've got 30 seconds. Team Asia, thinking, discussing, busy over there. Audience, I hope you've got your apps all working, got your voting going. That's your time up now. Team Asia, could we have your answer, please?
So failing sternum and the gap between fractal components are the reason why we do this chest wall fixation. And major flail chest, more than 3 ribs, is another indication. And sometimes we do this procedure on the way out with this diagnostic approach. Severe contusions are not the real reason to fixate the ribs.
So you're giving us answer number 1?
Yes.
So Asia's answer is number 1. We'll see what the expert thinks of that later on. Okay, now over to our panel again. So I want you to score the scenario as presented by the Americas. Frank's gone for 8. There's a 9 from Julia, a 7 from Arvind, 8 from Volta, 8, 7 from Akif, 6 from Dr. Chida. Can't see, it's a 9 and a 9. So that's the scores for the scenario. And moving on now to your scores for the answer to the first question as given by Team Europe. Or 10 and a 10, a 7, an 8, a 10, there's a 9, a 10 from David, now a 7, an 8, and there's 2 10s at the end. Okay, one more now to Team Asia. The answer to Team Asia and the scoring for that, please. Frank, there's a 7, a 9, an 8, 8, an 8. We've gone for 8 from Alessandro. David's at 7, 9, a 9. There's an 8 and a 9.
Okay, got it? Fantastic.
Okay, so that's our scores completed for that section. We're now going to move on to the third scenario, and we ask Team Asia to present intervention for complications and late sequelae.
So it's a 43-year-old lady with no known comorbidities. She was referred with recurrent episodes of left colicky pain abdomen over a 10-year duration. The pain started 18 months after her fall from her terrace. She fell from a height of approximately 8 feet. She had no neurological injuries or signs of bleeding at the time of trauma, but she has been going to a hospital 3 times, on hospital 3 days post-injury because of left lower chest pain. A chest X-ray showed fractures of the left lower lips and a pleural effusion. However, no further diagnostic or therapeutic measures was taken at the time. She has lost all records of the event, claiming that she was being given psychiatric medications since the pain was deemed to be psychosomatic. However, a chest X-ray was performed 2 years after the trauma, which is like this. For her persistent pain, she came to our observation where a chest X-ray and CT scan were undertaken, and these are the images of the chest X-ray as well as the CT scan. So the question to Team Americas is, all of the following CT images are suggestive of a diaphragmatic injury except.
only 3 options for this one. What do those 3 images show? How good's your radiology? Your time is nearly up, and that's it up now. We now have your answer, please, Team Americas.
We believe that the image in number 2 does not show a diaphragmatic injury or is not suggestive of that. The cuts are quite low at the level of diaphragmatic crurae, and it's not possible to look at the level of the diaphragm at that point. Instead of number 1 and number 3, there is clear evidence that is higher cuts and that there are abdominal contents in the left chest. So we believe the correct answer is number 2.
Okay, so answer number 2 from the Americas. We'll now go on to the second part of our scenario.
So which of the following will be the next step in management of this patient? Choice 1 would be to perform a colonoscopy. Choice 2, to offer reconstruction of the diaphragm via thoracotomy, VATS or RATS for definitive management. Third would be to offer diaphragmatic pacing. Fourth option, to be reassure the patient that the trauma is unrelated to her abdominal pain. And fifth, to advise for a follow-up with a CT scan at 3 months.
That's time starting now, and you've got your 30 seconds. Team Europe to come up with your answer. You have to get the diagnosis right first before you can come up with a management plan. If you've got the diagnosis, and how are you going to come up with the right answer? 15 seconds to go. The pressure is on and building. Time is nearly up. The music rises. That's it. Time is finished. Could we have your answer, please, Team Europe?
So I think there was a CT scan there before that did show what looked like a diaphragmatic rupture. This patient is symptomatic from it, so I don't think 4 or 5 are appropriate. There's no indication for diaphragmatic pacing, and colonoscopy would give us no real more information than we already have. So we would go for answer number 2. She should have her diaphragm reconstructed via thoracotomy, VATS or RATS for definitive management.
So answer is number 2, and we now move on. We want the scoring from the panel. Start off with the scenario as presented by Team Asia. So we've got a 7, there's a 10, an 8 from Julia. Arvind is giving us a 7, a 10. Alessandra has gone for an 8. There's a 7 from David, a 9 from Akif, a 9. There's a 7 from Ricardo and an 8 from Dr. Kasivi. So moving now on to the answer as given by the Americas. 9, a 7, a 7, an 8, a 9, a 7, a 7, an 8, a 9, a 9, and a 9. All 9s at the end. So moving on for the final answer, did they get the diagnosis and the management right from Team Europe? We've got a 10, a 9, coming up a 9, a 10. We're scoring well here. 10, 10, 9. Dr. Cheetah's gone for 7. Ricardo's at 9, and Steve's got a 9. So there are answers for Team Europe. Okay. Now, I would like you to come up, Tamas, and give us the correct answers, and we'll get you to look at the audience and then a wrap-up after that. So go through the correct answers first.
Thank you. The team's task was quite complicated, as this is a low evidence topic, as I said. So what is the next management step? Initially giving crystalloid or the O-negative blood, the permissive hypotension and urgent transfer to damage control, or urgent transfer to hybrid operation and doing the job well. The second question, the second answer was the correct one, and that's the Kipling's what answer. The next one was what is the role of the thoracic surgeon? The first three answers were active, surgically active answers. However, the correct solution is no surgical intervention warranted at the present, and that's the Kipling's Y answer. So the early management, including roller and timing of VATS and the chest wall fixation, the exceptional case was to decrease the mortality rate, because all of the other positive sites are more or less proven and evidenced. These are the papers presenting these evidences. Yes, that's the surgical solution and the end result. The next question referred to the chest wall injuries, and the only one exception is when the lung surface contusion has a high degree. In any other cases, yes, the operative solution is possible, and it's supported by the ESTS textbook. The late complications story is that was an image-related thing, and the third solution was the proper one. And we have a good explanation of the different signs, which are the evidences of diaphragmatic injury. And the last part was what to do. And the solution, yes, offer a reconstruction of the diaphragm, and it's up to the surgeon's choice and the possibilities which way to go in and to solve the problem. Yes.
So could we now go through the audience votes for the first question? Pretty clear now that the modern management is to start off with O-negative blood and tranexamic acid. Obviously, the patient was able to resuscitate enough to get a CT. The second question split straight down the line, really, between the first and the last question. But because of the comorbidities, no surgical intervention was warranted. I thought the Americans were going down that line because they said they were going to wait before they made their final decision, but actually they opted for the incorrect answer. Next question, again, quite split across the whole range there, but the correct answer was number 5, and the next question, we all agree more or less that lung contusion, you've got to be very careful about operating on anyone with lung contusion. Okay, and the radiological question split again, and 43% got the correct answer, and the next question was fairly clear. I think Europe had an easy discussion there, good discussion, but an easy answer for number 2. Okay, and is that all our questions? If that's all our audience voting, we'll now get a wrap-up from Dr. Molnar.
That's yeah. It will come. Yes. So it's very important to have a correct taxonomy, what we call what. And acute chest is a penetrating or blunt trauma when we have an unstable patient and we have to do an emergency intervention. In the urgent cases, that's a different piece of cake. The patient is stable. We have time and place to go through the whole diagnostic chain, like flail chest, and it's very important that that's a lack of significant bleeding, and the late sequel, hematoma, empyema, thoracic, things like this. In acute chest injury, we have to arrest the bleeding and during the pleural space. The urgent cases, there are complex decisions, and a trauma intensivist team should be asked to come and make a common decision. And the late sequel, yes, it's an elective procedure, more or less similar to the empyema thoracic surgery, planned intervention, and that's where the VATS and RETs obviously have room to play. We have to control the bleeding, first drain and thoracotomy if it fails, or in a few cases, straightforward thoracotomy. And the air escape is for drainage and the ventilation also. We have to differentiate between the penetrating and the blunt injury because two policies to be followed, and it's for the very beginning of the history. The space occupation and the bleeding are tasks to cope with. The diagnostics should be simple and quick, and I have to repeat myself again, we have an unknown patient and there is no room for learning curves at that stage. So the clinical picture and the basic images will direct us. We are not alone. The blood and the air in the pleural space is for the surgeon, but the parenchymal level injury is for the intensivist or the ECMO or other issues. Of course, if it's a cardiac injury, no need for picking up the phone, but go for it and do the thoracotomy, which should be simple, quick, big enough, and the chest wall is forgiving, but the bleeding is not. My personal preference is for the left anterolateral thoracotomy. What's in acute trauma, I have to emphasize again, it's acute. We have an unstable and unknown patient, a lung contusion, an unknown anesthesiologist in the middle of the night. We don't know how familiar she is with the double lumen intubation, and we are under the pressure of time and out of the comfort zone. So just to compare and think, for the frail chest, anchorage of the free segment is the main issues, and we don't buy 10, 12 days only. So the evidences are lacking in condition of the underlying lung, the degree of the parenchyma injury. It's a physiology rather than the anatomy. The ribs are not weight-bearing bones. It's very, very important. Thank you. And what's about the fate of the metal pieces that we are putting in afterwards? Migrations, things like this. So there are the semi-urgent and late complications. Yes, room or definite indication for VATS and RATS. So at the end, be the captain of your soul and your team. Draining should be the first thought, and thoracotomy in special cases. And the take-home message is the chest trauma is a drain and see situation scenario in the majority of the cases. The lung contusion is an absolute caveat. There is a life on the other side of the diaphragm too. Damage is for control and not for panic. And festina lenta, as the Latin says, hurry up slowly. And the next scenario, please.
Thanks very much, Tamas. You've got some very wise words from a senior head there with a lot of experience in trauma. So thanks very much for the teams and the panel for the topic of thoracic trauma. I'm going to hand over to my co-chair, Enrico, for the next section.
Okay, so the next topic would be lung cancer screening. And it's a pleasure for me to invite Giulia Veronesi to the podium to give a brief introduction before the case scenario. After this session, there will be a coffee break. The coffee break will be at the exhibition, okay, at the exhibition hall at the main floor.
Good morning to everybody. It's a pleasure for me to introduce this topic. As you all know, lung cancer is the main cause of cancer death in the world, in the Western countries, with more than 100 cancer deaths every day in Italy. And we all know that detection at early stage is critical to have good results in terms of survival and mortality. And as you can see here, we have 80% survival in screening cancer. And we have now two randomized trials defining the role of low-dose CT scan screening with reduction in mortality. One has been released in 2012, is US big, large randomized trial. And the second is in a European trial with reduction of even more death, like 30–40% in 10 years. And all these studies have limited number of screening rounds, 3 and 5. So the main critics to lung cancer screening is related to the safety and the risk of false positive and overtreatment, overdiagnosis. But according to our data and other groups, when you perform screening in a trial, you have good results in terms of high rate of stage 1 disease, low number of recalls, 5–10%, much lower compared to the NLST, low number of false positive surgery, very low number of overdiagnosed cases, and very low radiation-induced cancer. So what happens when we will have an implementation on a large scale? We must take in care that surgeons will have the responsibility to follow the diagnostic algorithm, maintain low the rate of false positive, reduce the risk of overdiagnosis and overtreatment. Thank you.